Greetings, everyone, and good evening, good morning, good afternoon, wherever you are. And welcome to today's webinar, AfroPHC on education for the team in African primary healthcare. I'm Bongi Swanda, and I'll be chairing this webinar today. I'd like to start first by actually wishing our family doctors today who are having their family doctors day. Thank you for all you do across the globe in all your spheres of practice, and thank you for your service. Today, we'll be looking at the education for the primary healthcare team, and we have three luminaries from Africa, African leaders, who also have international influence in their work, who are joining us. We have Dr. Champion Nyoni, who is the nurse academic and scholar based at the School of Nursing at the University of Free State, Bloemfontein in South Africa. He's the chairperson for AfrIPEN and is also an academic. AfrIPEN is our region's representative in the international global. And Champion will tell you more about that on interprofessional.global and what work AfrIPEN is doing. We have Professor Abigail Kazembe, who is the Vice President of AFREhealth. And she's a professor in nursing in Kamuzu College of Nursing in Malawi. AFREhealth is also the WHO Collaborating Center for Nursing and Midwifery Partner. And Prof Kazembe will enlighten us on the work they are doing at AfREhealth. Last but not least is Professor Bob Marsh, who is a professor and executive head of Department and Emergency Medicine at the Faculty of Medicine and Health Sciences, Stellenbosch University in South Africa. Prof Marsh is an established primary care researcher and chairs the Global Primary Healthcare Research Consortium. Most of us who are in family medicine, who are family nurse practitioners, will also be aware of the handbook that is Afrocentric, published by Prof Marsh, the Handbook of Family Medicine, which we mostly use as a core textbook in many different countries across Africa and beyond. Just a few housekeeping on the on how we are going to navigate this webinar today. If we could just go through the slides. And in the background, we also have Professor Shabir Musa, who will be supporting us as we go through this webinar. So if you can check your settings, and really would love you to get engaged as much as possible by using the Q&A and the chat boxes and raising your hand, particularly in the Q&A. So you'll see those arrows demonstrating that and how to control it. So about AfroPHC, I'm one of the core team members on the AfroPHC and representing APN Africa, in particular family nurse practitioners. We are a team brought together for leaders of the primary healthcare team from different professions, include family doctors, nurses, nurse practitioners, clinical associates, and community health workers, as well as public health professionals and allied health professionals. Our goal really is to support each other in development and advocate for appropriate team-based primary health care and strengthen health systems in primary care in order to achieve UHC across African countries. We also have a leadership program that is currently ongoing. And if you look at the website, you'll be able to see more information on that as we work on developing leaders. This webinar is part of our monthly AfroPHC series webinar. And today, as I've alluded, we're looking at education organizations. And these are really key education organizations in the region, focusing on health professions and interprofessional education. AfriHealth, where Prof Kazembe will tell us more about it, and PRIMAFAMED, Prof Marsh will tell us more about it, and AfrIPEN, Dr. Champion Nyoni will enlighten us on their work there. They'll be covering the questions on how their organizations work and the background of their organization, how that work in PHC, and their thoughts about our organization AfroPHC. There will be a question and answer after each presentation, and we'll have a longer one after all three presenters have presented. And we're going to be focusing on primary healthcare in Africa specifically. So it's over now to you, Professor Abigail Kazembe, to tell us about AFREhealth.
Good evening. I'm going to talk about AfREhealth. AfREhealth is an interprofessional health education organization that works with ministries of health, training institutions, and other stakeholders to improve the quality of healthcare in Africa through research, education, and capacity. Basically, we are a grouping of dedicated individuals from various institutions, associations, and networks from all over the world, and also including various linguistic regions of Africa. As you know that Africa is such a rich continent, we draw our membership from the Anglophone, Francophone, Lusophone, and Arabic. Our membership is basically open to African and other external stakeholders that are committed to an Africa with a strong, self-sustaining, and robust health system. So we are basically an interdisciplinary association. And regarding to what we believe in, we provide African leadership for responsive health professions education, training, research, and service in order to contribute to addressing key health priorities that include, but not limited to, HIV/AIDS, TB, malaria, MCH, NCDs, and COVID now as an emerging and repeat epidemic that has just shown up. So we are there to assist countries in these perspectives. As regard to the idea of how we work in terms of primary health care or supporting primary health care as AfREhealth, as we are a grouping of people that are interested in education and research, it is very important to consider people that work at these various levels. We know when we talk about primary health care in Africa, we are talking about, entry points to the healthcare system. So I can give one or two examples of specific things that AfREhealth has just done to look at issues of primary health care. For a long time, we have been working in silos, and the latest course that AfREhealth has developed with the support from HELSA and the University of California, San Francisco, we've developed a course which is interprofessional in nature. It is an HIV course, care, whereby even the deliverers of the course, the instructors of the course, are interprofessional in nature. And even the participants are also interprofessional in nature. We targeted those who have just qualified and those who have not yet been licensed to practice. We felt that this is a good starting point because they are going out there, but they will meet with all these other people that are very key in HIV care. And the whole idea is to improve HIV care in the African continent. And of late, responding to COVID-19, there have been a series of workshops that have been developed. And AFREhealth has been running these, and we have many more to run during the course of our time, because we are responding to a new epidemic that is out there. If you quickly go to our website, you'll find that there is a lot of information about COVID-19. There's some information about how to prepare your PPE. In other words, how do you put on and remove your PPE? And there are many more resources, as many as maybe over 50. And most of these have been translated in other languages so that other professionals in various countries can also understand and use the information. So if you go to afrihealth.org, there's a lot of information out there that talks about that. And also there are also current publications or information that have been written about COVID-19. I think already you've seen the controversy surrounding hydroquinone. And there's a warning there just to warn health professions to say, as much as there's so much talk about it, but we need to take precaution in its use. So it is a rich website, and I can give many more other examples. And the other area that I want to also look at is, how does AfriHealth view AfriPHC? As an association, we believe that we are addressing the same problem, which is looking at primary health care, which is the very cornerstone of any healthcare system in Africa. And the AfriHealth supports that perspective. And there are many more other associations in Africa which are interprofessional in nature. For example, we have close links with the PRIMAFAMED, which is a family network in Africa. We do have nurses, physicians, and all those people. We are in partnership. And all that is because we want to improve the quality of healthcare. I think for now, I can stop there. Thank you.
Thank you, Professor Kazembe. Any questions for Professor Kazembe? Thank you very much for telling us about AfriHealth and what you do in the sphere of Africa and at a global level. I suppose I'll start with one question before we move then to Prof Marsh, Professor Kazembe. Given that this is the year of the nurse and the midwife, and that the AfriHealth has a really key role in terms of being a partner with the WHO Collaborating Center for Nursing and Midwifery, what plans, if there were any, that AfriHealth had before COVID-19 interrupted us, or is there anything else that is going on at the moment that we need to look up for? Okay, it seems I may have lost Prof Kazembe there temporarily. Nonetheless, we will go to Prof Marsh. Prof Marsh, over to you.
All right, thank you very much, and good evening to everybody. I assume you can hear me. Yes? Good. So yes, so I'm going to actually start by saying a little bit about the education of the primary healthcare team, which I believe is the topic of tonight's discussion, and then a word or two about PRIMAFAMED. And so on my opening slide here, you can see that I have put in the World Family Doctors Day logo, just in celebration today, anyway, of family doctors. And the theme is Family Doctors on the Front Line, which is, yeah, quite appropriate for, with the COVID-19 epidemic. So I thought I would start actually what I want to say with this framework. Hopefully this is familiar to most of you on the call. This is the Primary Healthcare Performance Initiative Framework. So this is a global framework that has tried to distill the essential components of an effective primary healthcare system. And their intention actually was to try and find ways of measuring all of these components. I find it a very useful overview of what it is that we're trying to put in place. And I've outlined in the red lines the parts of this framework that relate to the primary healthcare workforce. And you can see in the middle there, under service delivery, we have the availability of effective primary healthcare services. So our providers must be available, they must be competent, they must be motivated and able to engage in a respectful and trusted and person-centered relationship with their clients. And then on the left-hand side in the inputs, you can see in the workforce, there comes in the education and training of this primary healthcare workforce and the human resources for health policy. Okay, next slide. So this is really to remind us that, of course, the education system is in a sort of symbiotic relationship with the health system, which is on the right-hand side of this slide. So on the far right, different countries in Africa, of course, although they've all signed up to the Astana Declaration, in reality, they have quite different political commitments and policy commitments to primary healthcare. I think many countries are still very hospital-centered, even just central hospital-centered in their view of the health system. Some are still very vertical in their approach and vary quite a bit in the percentage of the health budget that is actually given to primary health care. So that, of course, then determines what is in the center, which is what different countries think the primary healthcare team should look like and what the roles of the people in that team should look like. So in some countries, it would be primarily nurses. In other countries, it would be primarily clinical officers. In some countries, that team would include a doctor. In some, it wouldn't. In some, it would also include community health workers, and so on. And then on the far left is actually the education system, the training of that primary healthcare team. And of course, the training system has to align with the expected roles of those team members and is hopefully aligned with a supportive policy and political environment. Okay, thanks. Next slide. So one of the ways that I think about what it is we're trying to educate, to train, is this concept of medical generalism. So this can apply to all of the primary care providers in the team, and some of the commonest members of this team I've listed on the left: the nurse practitioner, the medical practitioner, the clinical officer, and the community health worker. And these are the features which I think we should be trying to train in all members of the team, and that they should actually all be, in a sense, be unified in their commitment to be medical generalists. So you can see that these features are that they should be seeing the person as a whole. This is the so-called biopsychosocial approach, seeing the person in the context of their family and in the context of their community, being competent to deal with undifferentiated illness, and taking responsibility for continuity of care with that person over time in primary care, as well as taking responsibility for coordinating that person's care when they move between levels or between the primary care facility and the community, or even in some cases within the primary care level itself between different teams. And then finally, having the ability to assist this person across the whole life cycle, from conception to end of life care, and across the whole burden of disease. So not just vertical programs. Thanks, next slide. So coming specifically, I suppose, to the bit of this that I'm most connected to, which is the role of the doctor or the family doctor in the primary healthcare team. And we have conceptualized this in South Africa in this way, that there would be, in essence, these three major areas for the family doctor. The one would be, of course, being a competent clinician and usually a consultant to the primary care team. So not the first contact person, but a very important member of the team in supporting the other first contact people. The clinical governance role basically relates to improving the quality of care offered by that team and the safety of patients. And then maybe the bit that relates most to today's topic, the actual building of the capability and capacity of that team in service, as well as clinical training of students and others. And then what I've said is that these three major roles, they can be applied at different levels. They can be applied in the community itself with teams of community health workers in a COPC approach. They can be applied in the primary care facility. And as you know, often in our context, they're also applied at the district or primary hospital. And sometimes the family doctor works across all three of these levels. Thanks, next slide. Okay, so having given that little bit of a sort of background of some of what I think are the key concepts in educating the primary care team, we come to PRIMAFAMED, which is the Primary Care and Family Medicine Network in Sub-Saharan Africa. So this, here you can see actually members of the network. I think this was when we met a few years ago. I think this was Ghana. I think that's Accra, but I might be wrong. But you can see all the different people in the network. Next slide. So PRIMAFAMED, as the name implies, is a network. We're a network of organizations. We're not at the moment a legal entity in our own right, but we are a network of academic departments of family medicine and primary care, really across sub-Saharan Africa. So in the map, you can see all the different countries and institutions that are part of the network. So if you add them all up, there's about 25 countries that have participated and about 40 institutions in sub-Saharan Africa. And then outside of Africa, we also have a number of international strategic partners. The University of Ghent in Belgium has been a particularly important one, the Besroor Center in Canada, and several others. So officially, we have, and as you know, Shabir is the president of WONCA Africa. We have negotiated, or we have agreed with WONCA that PRIMAFAMED would be sort of the academic wing of the World Organization of Family Doctors in Africa. So our focus is on education and training and research. And in that, in the research side, I know that's not the topic today, particularly, we have been a founding member of a new global primary healthcare research consortium, which is attempting to focus on key research questions in low and middle income countries globally. And I think a number of the PRIMAFAMED countries are already starting to participate in that research consortium. And then finally, we actually are a member. We joined AFREhealth. So our previous speaker, we're actually a member of that organization, AFREhealth, and I think we've participated in one or two of the meetings. So we're trying to raise the primary healthcare voice within that organization. I think another very important initiative of PRIMAFAMED was the establishment of the African Journal of Primary Healthcare and Family Medicine. This is the current homepage. And you can see from the editorial there earlier this month that we've launched a special collection on COVID-19 and are calling for short reports on COVID-19 from the primary healthcare level. So encouraging people to share experiences, innovations, learning in a short report from your different countries. So those will be fast-tracked for publication. In terms of our specific work in the development of family medicine training, our focus, I guess, historically has been a little bit more on postgraduate and to some extent undergraduate training. And the way that we've conceptualized the region is actually using the stages of change model and almost sort of mentally aligning countries as being in contemplation of family medicine training, or in action, or in maintenance. In some cases, pre-contemplation, and in some cases, probably some sort of permanent change, and maybe relapse even in one or two. But these three stages are where most countries are. And in contemplation, this implies that this country has not started family medicine training, but the key role players, which is usually the Ministry of Health, the universities or training institutions, and the national registration body, have not yet decided if it's really important to invest in family medicine training. Once they have, I can go back to the previous slide, that'd be great. Once they have decided, then you move to action. And then the number of countries which are in action, so the program has started, but they have very few or no graduates as yet. So this would apply, for example, to countries like Zambia, Zimbabwe, Malawi, that are pretty recent on the scene. And then maintenance, this would be where programs are well established. Graduates have kind of come out and have now entered and are establishing themselves in the health system. So countries such as Uganda, Kenya, Botswana, South Africa would be at this stage or even a little bit further. Thanks. Next slide. So what we have focused on in PRIMAFAMED is a targeted support and a South-South collaboration with also South-South-North collaboration around a country's needs, depending on what stage they're at. So in very broad terms, if you're in contemplation, then we would assist you with your conversations with your role players, with advocacy and knowledge translation and the evidence base. If you're in action, we would assist you with curriculum design, with initial support to the faculty. Often in country, there's very little senior faculty, and sharing educational resources from other countries to help. And if you're in maintenance, we will be looking at assisting you with your high stakes assessments, development of them, the further development of clinical trainers in country, and the further development of faculty to deliver and run the programs. So in very broad terms, that's kind of some of the educational actions, activities that we're involved with. I think that is the last slide. Thank you.
Thank you very much, Prof. Marsh, for that overview of PRIMAFAMED, and we now know what you do in terms of education and research to advance family medicine and primary care in the African space. Suppose I have one question for you, basically based on the presentation that you've done. We have clinical associate trainees, family medicine. We still need to implement more courses. We still need to have family physicians increasing in numbers in Africa, where there is actually low uptake in some countries. We are introducing family nurse practitioners in primary healthcare, and some have been already in progress, such as in Botswana, where they didn't have family physician for a long time being trained in Botswana. But we have new courses such as in Swaziland and the ones coming up in Tanzania. Given the low number of family physicians already, and with this responsibility of supervising so many clinicians and trainings and having to also ensure that we're having the right numbers of doctors, what is the role really of PRIMAFAMED, particularly within AfroPHC, to ensure that this happens and that there is investment in family medicine and in all PHC teams?
Okay, so your question, if I've got that right, is what is the role of PRIMAFAMED in essentially advocating for family medicine in sub-Saharan Africa? Is that?
That's correct, to ensure that we have sufficient numbers of family physicians to supervise and provide consultants in primary care.
Well, I think in terms of advocacy, our role is first of all to create local evidence. We have to have, because most of the evidence in family medicine historically comes from Europe and America, and not so much from low and middle income countries. So countries that have established family medicine and where family physicians are engaging and being part of primary healthcare teams, they actually have to generate the evidence in Africa that family medicine is making a useful contribution to district health services and primary healthcare, and then to use that evidence in advocacy and knowledge translation with these key role players in other countries, and to explain what family medicine actually looks like and is in Africa, because I think a lot of people also tend to think of family medicine on a European or American model, and I think in Africa it's a different model. And so politicians and ministers of health and sort of high-level policymakers have to kind of understand what the contribution of family medicine is in our health systems, and have to understand the evidence base. We have to be able to communicate that evidence in policy briefs and in ways that kind of make sense to policymakers. And underlying that, we have to actually generate the evidence to be able to sort of put our money where our mouth is. So I think I would say that that is, to some extent, what PRIMAFAMED's role in supporting different countries who would be at that sort of contemplation phase. That's what it would involve.
Thank you for that comprehensive answer, Prof. I'm just going to open up to the floor. So, see, Judy, I'll unmute you. Go ahead, Judy.
Unmute myself. Sorry. Good evening, everybody. Can you hear me?
We can hear you, Judy. Thank you.
Professor Marsh, thank you so much. Your presentation makes for interesting contemplation. And I just wanted to ask your views around this phenomena that has cropped up in the last, I want to say, decade or so, that is called task shifting or task sharing in the context of primary health care, of course, which came in as a result of the the HIV pandemic that hit us in the 90s, and will even get worse with these issues like COVID that we are in at the moment, because one of the challenges I see or have experienced myself is that when the numbers of patients are so high, then we keep shifting tasks to lower cadre, so like from doctors or physicians, perhaps to nurses to community health workers has sort of been the trend. And I want you to just discuss that in light of the training and education of health professions and even the delivery of healthcare services in this PHC context. Because the understanding is that primary healthcare is going to work towards giving access to, more people are able to get healthcare. And if we are doing this simply because of other reasons, perhaps speak a little bit to that. Thank you.
Okay, thanks. I mean, the way I kind of see it is that task shifting is really a sort of a global phenomenon. I think if you go to high-income countries, you see that, of course, their primary care teams are often doctor-led, but they're sort of shifting in the direction of adding more nurses, more clinical associates, and so on. We're kind of the opposite. We've kind of we've got a lot of nurses, a lot of clinical associates in the primary care team, and I think we're slowly shifting as well towards adding a small amount of doctors and other levels of expertise in the team. So I think in Africa, task shifting must not be an excuse to offer a lack of comprehensive and a lack of quality primary care. I think task shifting must be done within people's sort of scope of practice and within what is competencies can be delivered given the educational background and type of educational programs that people are engaging with. And we have to construct a team that is then capable of offering quality and comprehensive care. I mean, if I can very quickly give you an example. So we've been working on helping people with stroke in the Western Cape, and we have task shifted from therapists or nurses trying to educate caregivers and stroke survivors towards community health workers in the home, educating and assisting caregivers and stroke survivors. And that has worked really well because the task shift is within the roles and the scope of practice and competencies of the community health worker, but it requires input from higher level therapists and people with sort of higher level expertise. So they're still needed, but have a different role. And they have had to shift it in understanding their role, so that, you know, they're going to have to move away from a sort of individual therapeutic approach towards a role that is about supporting a team of people, which includes community health workers. So I don't know if that's sort of maybe a practical example.
Thank you, Prof.
Thank you, Prof. And now we are going to move on to the next presenter, then we'll take further questions from there. So next, over to you, Cham.
Thank you very much, Bonnie, and good evening to everybody. Welcome to this short presentation that we're going to introduce and talk to AfrIPEN. I just wanted to first express appreciation to Shabir and the rest of the AfroPHC core team for working flat out to create these webinars and actually creating a platform in which all of these various organizations can actually start to talk and communicate. And I think this is a brilliant initiative. Next slide. I wanted to start this presentation from a position or an area that is quite common to all of us. And this is to talk to what essentially is interprofessional education. Before we even get to discuss what AfrIPEN is and what it does, I wanted us to share a common definition of interprofessional education. And similarly, the literature is talking about a situation where we're having precisely students from two or more students from different professional backgrounds that learn from, with, and about each other. And we have seen different cases of definitions or applications of IPE, but the premise around IPE looks at the ability of these students to learn from each other, to learn with each other, and also to learn about each other. So students that sit in a class for an anatomy lecture, for example, do not necessarily practice IPE, but should they have an opportunity to be in a climate where they can learn from, with, about each other. And then from the WHO, the whole premise around IPE looks at a process where if we can actually teach our students in an interprofessional education climate, nested within our own health systems, driven by our own local health needs, we're most likely to graduate collaborative practice-ready health professionals. And if our professionals are ready to execute collaborative practice, it's most likely to strengthen our own health systems. We get optimal health services and eventually get improved health outcomes. So this is the footing where we're starting our discussion from. And so that's the next slide is just talking to now what then is AfrIPEN. So AfrIPEN stands for the Africa Interprofessional Education Network. So what it focuses on is that we have a vision of establishing interprofessional education and collaborative practice and making it an integral part of the training of the health workforce for effective functioning of the systems. And we are looking at it from an African perspective based on our African needs. In 2015, this is when our AfrIPEN, or the AfrIPEN organization, was formed in one iconic conference in South Africa. And over the years, we've managed to establish a biennial conference where we reflect and look at what we're actually doing and how best we can actually do to meet the needs within the African context. In 2017, the conference was in Windhoek, and at that time it was under the leadership of Dr. Stephanos Snyman from Stellenbosch University. Last year we met in Kenya, and we're hopefully going to meet again in an interprofessional education and collaborative conference, hopefully in Malawi in 2021. The next slide. So in this slide, I just wanted to show you, as I presented the initial definition, that we are a partnership of individuals and organizations. So essentially we have a facilitator who's more or less the chairperson of the AfrIPEN board. And this facilitator has specific functions and works directly with an executive committee. So the executive committee looks at the day-to-day business or the day-to-day operations of AfrIPEN. And we work collaboratively with a 12-member board. And so this board comprises of specific leads within working groups, and I'll talk to working groups shortly. And then we also have regional representatives, and Judy Genyola is one of our regional representatives from East Africa. And we also have Doreen Mokona from the University of Zimbabwe, who's also a representative of the region within Southern Africa. Then this, the organization also works with specific universities that become members of AfrIPEN. In as much as at this particular stage, we're still not having all African states and all African universities part of AfrIPEN, and that's the dream. We still have quite a number of universities that work with us. And then we work with IP.global or the interprofessional.global. So interprofessional.global can be seen as the federation of all interprofessional education networks globally. And so we work together in setting out specific mission and vision for interprofessional education and collaborative practice globally, and we operationalize some of those objectives or outcomes within the regional networks. AfrIPEN is also a core team member within the AfroPHC structure, and we have had cordial relations with the Sigma Theta Tau International, the Tau Lambda. So this is an honor society for nurses. We've also worked with the WHO, and currently we are working on strengthening our relations with the South African Association for Health Educationalists, where AfrIPEN is working towards being a special interest group in interprofessional education. And again, working with the technical working group on interprofessional education of the AFREhealth. And we are recently working in creating this new structure, which is known as AfroVibe. So AfroVibe is African Virtual Interprofessional Education. So it's part of a new approach, particularly for our students, the rest of Africa, where they do not have structured interprofessional education opportunities within their universities, to move interprofessional education into a virtual space and then create a strategy in which we can support them and engage them within IPE. So if students are enrolled in one university and there is not an opportunity for IPE, we're hoping that through AfroVibe we can integrate IPE but within a separate time. We are also working with AFIC, which is the Africa Interdisciplinary Conference, and we are co-hosting a conference in August around interprofessional and interdisciplinary activities. So in this particular slide, I was just showing you some of the approaches which we call work groups. So work groups are more of your thematized areas that work on specific issues within AfrIPEN, and they target specific parts and work towards meeting the mandate of AfrIPEN. So we have at the current stage 5 working groups with specific areas. The capacity development working group, for example, the main aim of this working group looks at developing capacity to deliver IPECP, particularly looking at the facilitators. Some of its achievements include that they've edited a special focus issue within the Journal of Interprofessional Care that looked at IPE activities in sub-Saharan Africa. They have developed specific IPE facilitator competencies, which are working towards the development of a continuing interprofessional education short learning program, which we are hoping to roll out because the premise is always that we want to have IPE in our institutions, but then we forget that the faculty still needs to have capacity on how to deliver IPE. So that is one of the long-term activities for this particular working group. And we've recently added within its achievements that they've started webinar series where they host specific experts within IPE globally. And the last webinar, which was held a couple of months ago, featured Professor Jill Thistlethwaite from the University of Technology in Sydney. And the whole idea was to expose the faculty within Africa and part of AfrIPEN to general principles around IPE. So the situational analysis working group is looking at actually determining the status of IPEC in Africa, who's doing what, where, how, and what has been the story around it. So they work closely with interprofessional.global because it is a mandate of interprofessional.global just to create a footing of where is the globe in terms of IPE. So at the current stage, we have designed a questionnaire in collaboration with interprofessional.global, and that survey tool has been brought down to AfrIPEN. And at this stage, we are looking at contextualizing that particular tool and making sure that it reflects the African specific nuances before a survey can be conducted in our institutions. The policy working group focuses on developing policies and guidelines, particularly for IPCP in Africa. And what they've been working on in the last couple of years is gathering documents from each country relating to what are the IPCP policies, looking at accreditation statuses and assessments within education strategies and structures throughout Africa. And the idea is to contribute to the refinement or the review of the WHO framework on interprofessional education and collaborative practice. So one fundamental working group, which is the impact evaluation working group. So we have had a lot of discussion on IPEC, but a lot of our stakeholders find it very important that we provide evidence of the impact or the effect of IPCP in our systems. And we have at this particular stage developed a proposal that looks at specific sites within Africa, and we've got 5 countries that had volunteered to be part of this strategy. And the idea is to use that proposal and evaluate the impact of IPCP and share this to the world. And at this stage, the biggest challenge we're all facing is funding. And the proposal is out there, and we hope that it can start moving. Lastly, the communications working group looks at displaying IPE activities from Africa and from AfriPEN. And this is through our website, through our social media presence, and a newsletter that is shared in every quarter. Next slide. And so just to sum up from our side, I think in terms of PHC and in terms of AfroPHC, I think the biggest lesson that we've all learned in terms of the importance of PHC and again, the integration with AfroPHC comes from the state in which we are all in. This is the state related to the COVID-19 story. That it's clear that there is no individual profession that can actually work alone and get things done. There is no individual district, there is no individual province, there is no individual country that can actually lead to universal health coverage. We are all working in an interdependent, collaborative team that if we are aiming at universal health coverage and universal health access, it is not a silo or a one-man show, but we need to look at how best can we strengthen our interprofessional and collaborative practice to improve primary health care and again, universal health coverage. A few issues on some of the collaborative competencies that can enhance our practice looks at values and ethics within practice, strengthening team-based work and shared leadership within the teams. And I like it when there's the discussion about task shifting and task sharing and looking at how clear are the responsibilities within the members of that particular team. And an active and sensitive communication between the health professionals and their community, and also looking at shared accountability and reflective practice. So as AfrIPEN, we are a core team within AfroPHC, and we are hoping that this will strengthen universal health access, universal health coverage, and then there's better outcomes for our systems. Lastly, last slide. I think you can contact us on afripen.org. You can send me an email, and on Facebook we're available as AfrIPEN, and also on Twitter. Thank you very much.
Dr. Nyoni, we appreciate your leadership and the work that you are all doing at AfrIPEN. We are absolutely excited to hear about the regional level you are doing to represent Africa in progressing IPECP. I suppose I have one question for you. What we hear from our students, really not necessarily in Africa alone, but from your side, I can still see that gap too. But from a global perspective, is that IPE is well embedded in higher education in most institutions. But when they qualify, they don't see this happening in clinical practice. How can we bridge that gap?
Yeah, that's a very important question. And like you're saying, that our students are in that situation where they describe a rather theory practice gap, that this is what is being practiced within institutions, but when we go into the environment clinically, that doesn't really happen as envisaged. And my position around that story is that currently we need a strengthening of the systems. And one way of strengthening the systems is creating awareness and sensitivity to the current challenges that the health system faces, particularly in relation to poor collaboration. I mean, the international organization, IOM, has been pointing out specific issues that have been correlated to poor collaboration. And this is not evident within some of our practitioners in practice. But again, we also need to look at developing contextually relevant strategies within our health systems. It's a little bit easier within the in education because the students are in a structured environment. But how do we engage our clinical environment to strengthen continuing interprofessional education? And I think at this particular stage, we could think of taking advantage of societies and organizations, for example, what AfroPHC has brought together, and look at how do we trickle the message of collaborative practice, the strategies of collaborative practice within individual professional societies, and create platforms for such discussions. Another issue that one could also look at is engaging with standards for institutional accreditation and looking at how do we embed collaborative practice within institutional accreditation standards that it becomes common practice within hospitals. So I think that can be a shared thought on how best collaborative practice can be tackled within our health systems.
Thank you, Dr. Nyoni. Absolutely, I concur with your answer as well. We need to have IPE not rather as a tick box really in higher education, but something that's embedded, and we continue with it in clinical practice to ensure that collaboration occurs. I will now open the questions and answer to our participant. We have one question from Chelsea for you, Dr. Nyoni. She's asking if AfroWOM, which is a Young Doctors Association, whether they can join AfrIPEN.
Yes. Yes.
Okay, thank you.
Bonnie, you are muted.
Judy, go ahead. You can unmute yourself.
This is directed to all three presenters, and thank you for your excellent presentations. It's just, maybe it's rhetorical. Toric and others can weigh in. But this COVID-19 pandemic and the 2 months we've all been somehow isolated, lockdown, whatever, has, for me, highlighted the need for leadership. And you can see how leadership in different countries spawns a different response to the pandemic. Case in point, you know, Tanzania. I'm in Kenya, and we have a bit of a fight between Kenya and Tanzania at the moment just because of this COVID. I hope it won't degenerate into war. But I want to ask you what the role of us as healthcare workers is when it comes to such things, so that we are at the forefront of providing accurate and correct information regarding health issues. You know, PRIMAFAMED, AfrIPEN, AFREhealth, all of these, you know, the way you've explained the organizations, very articulate and clever and all that. Still, somehow, we don't see that force coming out when we need leadership at times such as this. What can you say?
I'll bring one of the presenters to answer that question. Let's just give 1 minute to answer it.
Well, it's a big question. Look, I think in many countries, I mean, the amount of information flying around on COVID-19 is actually enormous, especially, of course, on social media and all of these other channels. And I think that there is good information out there. I mean, for example, in South Africa, the NICD has, you know, very, very comprehensive website. I'm not sure, you know, for an organization like PRIMAFAMED, it's helpful to kind of duplicate or a lot of that. I think our role is actually to try and connect people to credible, evidence-based and reliable sources of information. I mean, if you're talking about health professionals and you know, primary healthcare team members, so I think. So certainly, you know, the Academy of Family Physicians in South Africa, and I would think PRIMAFAMED and other organizations, I think our role is to connect people to credible sources as much as we can within our own networks, and to provide links to those, to the evidence base that is there and that we should be using. And as you see, I think the journals are also trying to disseminate credible information about what people are learning in different countries that can be, you know, transferred into other contexts.
Thank you, Prof. Marsh. I hope that answers your question, Judy. We're just gonna bring in Prof. Shabir, and yeah, from the first slide. Prof. Shabir, can unmute yourself.
Is that, can you see me?
Yes, we can see you.
Okay, great. Well, I just asked the question, which I wonder if the you know, the panelists could answer. What are your thoughts around advancing the primary health care agenda within universal health coverage? As educationists, what do you think we could be doing as AfroPHC to make sure that primary health care is lifted in universal health coverage discussion? I think I'm raising it because with the current COVID crisis, everybody's thinking hospitals. Primary health care is in fact marginalized, and many people are actually shutting down services in primary health care as a knee-jerk reaction to this organization, and the fact that it's not seeming too important in this crisis time. How do we lift it and make sure that it does get addressed? Perhaps each of the panelists could answer that.
Prof. Kazembe, would you like to go first? Do we have Prof. Kazembe with us? Champion?
Oh, sorry.
Oh, okay. I thought we had lost you. Sorry, Prof. Yes, you can go ahead.
Yeah, network keeps cutting on and off. Yeah, I just want to respond by saying that I think this is a good example, COVID-19. For example, in some of the poor countries, maybe mine being an example, is maybe one way of using the primary healthcare approach is that maybe our hospitals cannot accommodate everybody, and we may not have all the resources in there. So maybe instead of pushing everybody into the facilities, people that are sick, some are left at home, and the care is being provided in their home. They're being visited in their homes. So I see this as it may not be the best that we can offer, but it maybe it's one way of making sure that we are using our entities in order to promote, care. Maybe the challenge would be the issue of human resources, because we have all been oriented to work in hospitals. Very few people work in the primary healthcare settings. But I think now it's time that we start thinking the other way around, to invest more in these facilities other than in the bigger facilities. That's my take. Thank you.
Thank you, Prof. Absolutely. I mean, patients in primary care are becoming more and more complex, and the challenges we're facing are also becoming complex. Our community health workers play a critical role in the community, and really we need the investment to go into education, and we need to have the appropriate support, including leveraging on technology really and innovation in rural settings and in primary care as a whole. Yeah, go ahead, Champion.
I think it's just echoing what Prof Kazembe and what you're talking about in terms of looking at primary healthcare and access to universal health coverage. And I might speak from it at purely an educational perspective, that I think we need to look at how do we best aggressively engage our stakeholders with the evidence that we're having in front of us. And like what Judy is pointing out is that we are having eloquent and state-of-the-art organizations, but it's not translating to what's happening on the ground. And that culture of adopting evidence and using evidence or knowledge-driven type of decisions is not within our perhaps continent. And that's why we keep on having generations of evidence, universities, centers of excellence, but what happens on the ground is a little bit different. So it looks at how best do we strategize and engage aggressively with stakeholders, both in education and in practice, that we become more or less a knowledge-driven situation, society. And again, looking at it from education, I think it is high time that we start to aggressively engage with the restructuring of our education structures and strategies, and move away from this type of hospital-based training and engage our students within our communities and within our primary healthcare environment, because that is where the need is, and that is where we're hoping that after this training, they're most likely to work and make a huger contribution. I mean, we are seeing that primary healthcare is a starting point for our health system. So I'm thinking of how best do we look at re-strategizing and structuring our education approaches to be primary healthcare driven, with our students spending time within the primary healthcare environment and engaging evidence to drive decision making both within education and also in practice. Thanks.
Thank you, Dr. Nyoni. Prof Mash, any final words on what we can do as educationalists to enhance primary healthcare and UHC?
Okay, final word. Yes. Well, I think, Shabe, you almost asked two different questions. The one was, how can primary healthcare contribute to UHC? And then there was a COVID-19 question. I think looking at the COVID-19 aspect, having a community-orientated primary care approach in COVID-19, I think has proven to be incredibly useful in the South African context, and having that approach to primary healthcare, because I think that most of the response actually to COVID-19 can be in the primary care space. I mean, the suppression and containment of the epidemic through community screening and testing, the case investigation, contact tracing. 80% of cases, of course, are mild cases and will be treated at home or in primary care. And then having a COPC approach has also allowed us to keep people with non-COVID chronic conditions out of harm's way, for example, through delivering medication in the community and so on. So I think that actually having strong primary healthcare and specifically educating people for COPC is fundamental to actually having a good response to a crisis like COVID-19. Maybe that's my final word.
Thank you, Prof. And thank you for those important final points on UHC and PHC as educationalists. I would like to take this opportunity to thank all our panelists. Thank you, Prof. Marsh. Thank you, Dr. Nyoni. Thank you, Prof. Kazembe, for coming today and really taking time from your very busy schedules to be with us and to share with us about your organizations. I would like to thank our participants who have joined us across the world. I saw some people joining from the UK, from the US, from Tanzania, from South Africa, from Zimbabwe and India. So we really do appreciate your presence today and to share this platform with us. I would like to refer you to our AfroPHC website, where you can join us to help us to accelerate and improve primary healthcare systems in Africa and strengthen PHC and UHC. We have a high level participation on our discussions in the Google group, and we also have an online training in health and leadership and management within an African context. You can also link up with PHC leaders from each of your countries, and you can join us in further AfroPHC webinars that we have. Without further ado, I will hand over to Prof. Shabir Musa. I may have a few last words.
Thank you very much, Bongi. I appreciate that you managed this meeting very well, and I hope that we can have you all participating more as we proceed. Thank you all very much once again. Have a good evening.
Thank you all. Have a good evening. Bye.